Dear Professor Alper, dear Professor Karakoç, dear Mustafa, dear Kaya, dear Ahmed, thank you very much for the invitation to this prestigious Congress. It's my second time here in Antalya, and I'm very proud to be part of this Congress. And this is one of my main topics that I do in daily life, minimal invasive liver surgery, and I'm very honored to have the possibility to share some thoughts about the past, the present, and the future of minimal invasive liver surgery. These are my disclosures. So the agenda is very easy: past, present, future, and summary. So concerning the past, I think if you talk about minimal invasive liver surgery, you have to think about the first laparoscopic cholecystectomy that was performed in 1987 by Philippe Moreau in Lyon. And he never thought about publishing it because the laparoscopy in these times was more a field of gynecology. And he shared a practice with a gynecologist, and they once had a patient that had a problem with the gallbladder and a gynecologic problem, and he just removed the gallbladder laparoscopically, but he never thought about publishing it. But of course, the rumors spread, and then the first laparoscopic liver resection reports were made in the early 1990s, especially by Gagner and colleagues, and Katasuda and Reich. And pretty much afterwards, the first left lateral sectionectomy was described in 1996 by Azara and Kaneko. And in the following years, the development was very rapid. The first reports about hemihepatectomies, sectionectomies, posterior superior segments, or extended and combined limited resections or multiple parenchymal sparing resections were done. Very important consensus conferences were held. The first one was the International Position on Laparoscopic Liver Surgery in Louisville, and about 50 experts met there and made the first definitions. They talked about the status and the indications for laparoscopic liver surgery. Education was one of the main points, even in the very early days, and of course a safe spread. So one of the most important quotations from this paper, in my opinion, is that a safe dissemination of laparoscopic liver surgery is the highest concern. Next very important consensus conference then was in Japan, in Morioka, in the department of Iwate, and there a defining role of laparoscopic liver surgery was one of the topics. Then a lot of papers were discussed discussing the non-inferiority to the open approaches, because when you have a new thing in surgery, first of all you have to show that it is secure, it is safe, and it's not inferior than the gold standard that is already established. So in these times, the colleagues started to develop recommendations and guidelines. Very important, especially for educational purposes, was the evolution of a difficulty scoring system. I will talk about this a little bit later. And of course, very important is if you have a lot of pioneers, you meet up together and you have to standardize the procedures, because if the procedure is a difficult one, you need standardization to make it educational. So this is very important, the difficulty scoring. It's past, but I think it's still current, and we still use it in my department when we make education of fellows and residents. So the Iwate criteria assign a point to each segment where the tumor is located. So we have very difficult segments like segment 8, segment 7, or segment 1, the posterior superior segments. We have easy segments, that is, for instance, segment 3. So we only get 1 point for this. But you also get points for tumor size. If the tumor is bigger than 3 centimeters, you get a point. Or if the liver function is bad, you get a point. Or if you have proximity to major vessels, you get a point. So depending on the extent of liver resection, you get other points. Or if you do this as a hand-assisted or hybrid procedure, you lose a point. So if you add up all those points, by the Iwate criteria, you can classify special minimal invasive surgeries into difficulty levels for low, intermediate, advanced, and expert. So for instance, right or left hemihepatectomy would be an advanced procedure, or posterior superior segments for segment 7 with a tumor bigger than 3 centimeters would be an absolute expert level. So it's nothing to train students or young surgeons with expert surgeries. Another very important thing over these years was the development of different approaches to the liver. And if you work minimal invasively on the liver, you first have to understand that you cannot reach the liver from frontal, but you have to reach especially the difficult segments more caudally. So the caudal approach for laparoscopic liver surgery was first described and is still in use. There are other approaches, for instance, for difficult segments, segment 7 or segment 8, the lateral approach, where you need a transthoracal trocar, or the thoracoscopic approach. But in my department, we only use the caudal approach. For the lateral and thoracoscopic approach, we're not convinced of. So this was kind of the past, so let's talk about the present. So these are just some landmark papers. After the retrospective design papers, we also had now randomized controlled trials, for instance, the Orange study. Then we had another consensus guideline conference for laparoscopic liver surgery from Southampton. Then this is a paper of attending surgeon of my group now, from Felix Kenzin, who established the International Laparoscopic Liver Surgery Society Fellow Skills Curriculum, what is very helpful for the younger residents. And right now, or a couple of years ago, we are already comparing minimal invasive procedures, like we're comparing the laparoscopic approach with the robotic approach. For instance, here in JAMA Surgery in 2022, the propensity score matching analysis comparing robotic and laparoscopic right and extended right hepatectomy. So for HCC, this is a meta-analysis of 44 studies of approximately 5,000 HCC patients. And in this paper was shown from 44 studies that, of course, if you make the minimal invasive approach, you have less blood loss, you have a lower morbidity and mortality, of course, a shorter hospital and ICU stay. And what was also shown in this meta-analysis, that there is no oncological difference. That means that it's non-inferior. A little later, the first publication of a randomized controlled trial with hemihepatectomies, open versus laparoscopic, was published by Fredland and his group, the Oslo Commit trial. And it's a bit difficult to read, but I read it to you here. So the postoperative complication was in the laparoscopic approach significantly lower. Also the comprehensive complication score, the postoperative hospital stay, and this is in hours, measured in hours. The patients that had minimal invasive liver surgery also needed less morphine equivalents and stayed shorter in the recovery ward. And a couple of years later, one of the group of Redland published the long-term results, and he could show that open and minimal invasive surgery randomized for colorectal metastasis was non-inferior. Dr. Knitter of my group in Berlin made a B-centric analysis with a propensity score matching, also for colorectal liver metastasis, and we could also show that we have in the minimal invasive approach a lower complication rate, a shorter ICU stay, a shorter length of stay, and less blood transfusions. And this, again, is a paper from Dr. Kranzin from my group. This is from a big registry, 60 international centers, more than 5,000 patients operated on robotic-assisted or laparoscopic, and this is a subgroup analysis for the patients with the very difficult locations in posterior-superior segments. That means segments 1, 4A, 7, and 8. And if the robot was used compared to the laparoscopic approach, patients had a lower conversion rate, lower blood loss, shorter operation time, and also if the patients had cirrhosis, the results were the same. So this leads us to the present of my department. We started around 2015 with minimal invasive liver surgery, and 2018 we established the robot in our department. We used the intuitive robot, and I had the great pleasure and honor to be trained by Mathieu, who will have the talk directly after me. And as you can see over the time, the number and the percentage of the patients that we can minimal invasively operate on the liver is steadily increasing. And about a quarter of our patients are operated on because of HCC, and about 40% because of colorectal liver metastasis. And if you establish a minimal invasive liver surgery program and you standardize a lot and you talk a lot with your scrub nurses and with your anesthesiologist, you can have very good results. So this is just from our quality data manager. You can see here, I try to get you through this a little bit. This is from 2020 to 2025, and these are all liver resections, the minimal and the open liver resections, and we compare the morbidity and mortality rate with the German national numbers. So as you can see, right now we are below 1% Clavien-Dindo 5, this means death of the patient, and we are very much below the major complication rate that we have nationally in Germany. And how can you accomplish this? It is much important that as much as possible minimal invasive procedures are done. You should include your minimal invasive liver surgery program into an ERAS program, Enhanced Recovery After Surgery. Of course, for the bigger resections, you should do future liver remnant volume planning. And of course, a long-term interdisciplinary cooperation helps you minimize the failure to rescue. So I take you to the OR with me a little bit. I will go over this very quick because a lot of you are, I think, very experienced in minimal invasive liver surgery. So for the OR setup approaches and trocar placement, just to have a look in our OR, on the left-hand side, you see our setup for the robotic, and on the right side, you see the laparoscopic approaches. So for the laparoscopic approaches, you have different possibilities. We don't use the single port so much anymore, but you can use it for left lateral sectionectomies. Then this is our setup for the multi-port. And the hand port we don't use anymore, but I think in the beginning of the program, it helped us a lot to establish also more difficult operations. Concerning this is a paper by my group published already in 2020, single center retro analysis, propensity score matching, about 300 patients. In the final analysis after the matching, we had 70 versus 70. And what we found is that in the hand-assisted group, there were significantly higher rate of radical lymphadenectomy or posterior superior resections. But there was no significant difference between the matched groups regarding operation time, conversion rate, frequency of major complications, length of ICU, or overall hospital stay or R1. So we concluded in this former times that the minimal invasive liver surgery and the hand-assisted liver surgery might be equivalent regarding postoperative outcomes, and the hand-assisted procedure might be particularly helpful for complex surgical procedures in the earlier stages of the learning curve. So as I already mentioned, I think the single port you can use for left lateral sectionectomies, or more common is a multi-port approach for the left lateral sectionectomies. For the right and left hemiapatectomies, we use always this multi-port placement. And of course, for the more difficult segments like segment 8 and segment 7, we would also use the multi-port, and we would stick to the diamonds technique by Abu Hilal. Just shortly before Mathieu will have 20 minutes for robotic surgery, I go to our approaches for the robotics. We usually, in my department, use a two-surgeons approach. As you can see here, we have the patient in French position, and we have an assistant surgeon between the legs. We have the console surgeon, and usually the patient cart, the robotic unit, comes from the left side of the patient, so the right arm is for the anesthesiologists. The assistant surgeon has his own screen. We have the scrub nurse here. Usually for the right-sided resections, we also make a little left rotation For the left-sided resections, you don't need to rotate the patient to the left, but we always recommend to use a reverse Trendelenburg of approximately 15 to 30%, depending on the physiognomy of the patient. These are our trocar placements. For instance, for right-sided hemihepatectomy, we use the 8mm Da Vinci trocars in these positions. I always recommend to have the camera a little bit more caudally, that you have a better view of the operation field, and we have two 12mm assist trocars where the assistant surgeon would apply clips or would use the suction device. We usually use an external Pringle, so we have another 5mm trocar here for the external Pringle. So let me summarize the present. I think in specialized centers, all kind of liver resections without reconstructions are performed laparoscopically today. Because of this steep learning curve, structured education is warranted, especially for those who want to perform Mayo resections and resections in the posterior superior segments and segment 1. From my point of view, if you make laparoscopic liver surgery, lymphadenectomy can be pretty tricky and also needs a lot of training. And I think the robotic-assisted liver surgery has overcome many of the obstacles of laparoscopic liver surgery, especially lymphadenectomy and reconstructive procedures are much more easily performed with the robotic telemanipulation. So what does the future hold for us? I think Mathieu will talk more about the future. But if we talk about the future of minimal invasive liver surgery, maybe we should look at the automotive industry. So if you look right up there, would you get in the car and let the car do everything? I don't know, but it's still possible. So I think right now, if we compare this to liver surgery, we are at this point here. We have assisted or maybe partially automated. Maybe we move a little bit to partially automated situations with our robots. And I don't think it's possible with laparoscopic surgery. You only can do this with the robot, because with the robot you have much more calculation power. The new Da Vinci system has like 10,000 more power in calculations than the old Da Vinci system. So I think the AI might be able in the future to establish partially automated or maybe highly automated procedures with the robot. So I don't know whether we ever will come here, that we become a passenger and don't even need a medical degree to do surgery. I hope we won't get there, but maybe it's the way in this direction. So the people from Johns Hopkins, they have a big lab about AI and operating procedures, and they published a couple of years ago this video paper in Science Robotics about autonomous anastomosis. So the video I show you right now, it's not of very, very good quality, but some things you will see from there. So this is in a pig model. They incised the intestine and then they fixed the intestine to the abdominal wall. And as you can see here, I think most of the work in this experiment was still done by the laparoscopic surgeon and not by the robot. And then it is possible to put some landmarks here. Then the infrared camera makes a plan for the robot to suture. So the AI says, I would do the suture here. If the surgeon is not okay with it, he says, okay, please try again. So these would be the better sutures. And then the robot can make the stitches. And it's totally automated, as you can see here. But if you look at the video quite well, you will see that the suture still has to be taken by the surgeon and pulled to the side. So it's just like the stitches are automatically made in this experiment by the robot. If I had a resident who would show me this anastomosis, I would fire him. But still, it's kind of a step in the right way. So the next paper by the guys from John Hopkins, or the next advertisement, was that the robot performs first realistic surgery without human help. Yeah? So what was this? And they made the quotation, "This advancement moves us from robots that can execute specific surgical tasks to robots that truly understand surgical procedures." I would still doubt this a little bit. If you look at the paper a little bit more closely, of course, the robot was able, by language training, to put the clips in the right way. But again, if you look at the porcine livers over there, if my residents would preparate like this, I would fire them. So we still have a long way to go. Okay, let's summarize. I think full laparoscopic liver surgery is now a standard procedure for treatment of benign and malign liver tumors. Mayer right-sided resections and resections of posterior superior segments, as well as segment 1 and lymphadenectomy, are, from my point of view, for experts and require a lot of training and step-by-step education. I would say the more complex, the more robot, especially for lymphadenectomy and for biliary reconstruction, the robot offers a lot of advantages over the standard laparoscopic approach. But on the other hand, until robotic systems become much more affordable, laparoscopic liver surgery will remain the mainstay of minimal invasive liver surgery. And we have promising experimental results that might lead to partially or highly automated robotic assistance in the future. Thank you very much for your attention.